Okay, I'd like to welcome everyone, and we're going to go ahead and get started on time today. I welcome you to the Endoscopy Now and final debate in the Surgery Then Endoscopy Now series, co-developed by the American Foregut Society and Endoscopy Now. I'm Sri Komanduri, a professor of medicine and surgery and associate chief of GI at Northwestern University in Chicago. I'll be one of your moderators this evening. So first and foremost, I want to introduce my co-moderator and our participants in today's hotly contested debate. First of all, my co-moderator is Vivek Hall, who's a Siegel Watson Professor of Medicine, the Center for Advanced Therapeutic Endoscopy in the Division of Gastroenterology and Hepatology at the University of Rochester Medical Center and Strong Memorial Hospital in Rochester. Welcome, Vivek. And then I'd like to also introduce both our surgical speaker and our GI endoscopist for the evening, and who will be debating tooth and nail here in a few minutes. First of all, it's my pleasure to welcome our surgical expert, Daniel B. Jones, a professor of surgery, vice chair of surgery at Harvard Medical School, Beth Israel Deaconess Medical Center. Welcome, Daniel. Thank you so much for making this tonight. And our endoscopy, or GI endoscopy expert, I should say, is Dr. Vivek Kumbhari, who's the chair of gastroenterology and hepatology at Mayo Clinic, Florida, adjunct associate professor of medicine at Johns Hopkins Medical Institution. Thank you, Vivek, for joining us, and we look forward for the battle that will ensue shortly. Very briefly, I just want to outline the format tonight will be each speaker, starting with our surgical expert, will have a short didactic session, sort of highlighting their side of the argument here, for lack of better terms, from a surgical perspective, and then a GI endoscopist perspective. In between, each one will be given the opportunity for a short rebuttal, and they can choose to use this if they wish to make any comments about the other's presentation. And then we will move on to a Q&A session, and then ultimately finish with a rapid fire to finish off any questions that we may have. At the end of tonight, we will have a quick poll that will pop up to see who you might feel has won the debate. We'll take that with a grain of salt based on the percentage of attendees that are gastroenterologists versus surgeons, but we'll get there when the time comes. Before we get started tonight, I did want to take a moment to acknowledge, for those of you who had not been present or have not had the ability to come and participate in the full series. This was a 4-part series as a prelude to the American Foregut Society meeting. So hopefully many of you are attending that meeting up and coming. We had many great speakers across the board. We want to thank all of our speakers who came to us, and with very short notice, the series came together very quickly. We look forward to moving this pilot to a more consistent series throughout the year, and increasing the breadth of our topics and speakers for this. And please, if you have any feedback around this series, we'd love to hear from you. Just as we get started here tonight, we're talking about the endoscopic and surgical interventions for obesity. This will be our debate. And with all the sort of, as the gloves get put on and the fight ensues, there is some obvious serious nature to why we're doing this. And this 4-part webinar series we put together is really highlighting the art and science behind the multidisciplinary approach to foregut disease. Both of our speakers will tackle things like current guidelines, difficult clinical scenarios, and controversies in management that identify unmet needs. But again, all kind of joking aside, while these debates have winners and losers, the objective of tonight's virtual event is really to emphasize the collaborative efforts of gastroenterologists and surgeons, which is really the mission of the American Foregut Society, and is one of the priorities for Endoscopy Now. And so tonight's webinar will showcase many of these surgical endoscopy approaches to the management of obesity and sort of the state of the art, and compare and contrast the pros and cons. And so the value of this collaborative multidisciplinary team approach will be highlighted as we venture into this debate. But with all that said, now we'll get to the opportunity to hear our speakers go at each other. And it's my pleasure to have Dr. Jones take the stage first as our surgical expert. Welcome and thank you.
Well, let me get back to start off saying it's a pleasure to be here. Also, I'd like to thank Doug Pleskow and the GI guys at Beth Israel Deaconess for doing a terrific job. But I did want to point out that usually when we're talking about surgery, we're talking about management of complications, we're talking about therapy. as opposed to just the procedures. That said, I'm going to try to concentrate on three of the more common procedures we do in surgery for bariatric surgery. Now, this is the first slide showing the epidemic in the United States. It's very clear. It shows that there's only two places that were too skinny and the rest of the country probably too heavy. And this probably also is very representative of the world as we move forward. As the BMI goes up, so do the healthcare complications. And I just pointed in one disease, diabetes, to show that as you get more abdominal fat, we move from prediabetes to type 2 diabetes. And this becomes a good disease as a marker of success with our weight loss procedures. Now, as I see it, the relevant issues that we're talking about tonight when we're comparing surgery and scopes is, for the most part, the surgical procedures, you're going to lose more weight. You're going to have more resolution of diabetes and complications. We have a built-in safety network with the MBSAIQ IP, which measures all of our outcomes on every single patient. We have accreditation programs for all of our bariatric surgical programs, and we have a very focused MIS bariatric fellowship. And because of all these things in place, we also have good insurance coverage. Now, my understanding with scopes is that you're usually cherry picking folks with low BMIs, people with money in their pocket because the insurance may not pay for it, folks who are very patient, waiting for multiple interventions to try to get a result. And I think these are the types of things that we hope to bring out in our discussion. Now, for surgery, we typically have talked about a BMI greater than 40 or 35 with these health-related comorbid conditions, by experienced surgeons in a clinical setting capable of supporting all aspects of management and assessment, and in a team that's committed to lifelong close medical surveillance as necessary. And I have you think about this to say, does your typical endoscopy unit really have this infrastructure of lifelong medical surveillance? Now, we can see that when laparoscopy took off, so did the number of bariatric cases. That all occurred in 1994, and today we're approaching maybe 250,000 cases in the United States. And I'm old enough to say I got involved in this in 1997. This is just the standard that we have, the MBSQIP. Every single operation goes into a database. We've tracked the outcomes of every single complication, all the results. They're not made up. These are real. Now, the common operations that are done in the United States are the laparoscopic gastric bypass, shown here. The laparoscopic adjustable band was very popular and is done less frequently today. And one with the biggest sort of popularity, I think, across the United States at least, is the sleeve gastrectomy. Now, it's worth saying this isn't the endo sleeve, because what you see is a large part of the stomach is missing. And in that stomach, there's ghrelin cells that go to the brain that say, hey, I'm no longer hungry. So it's not just about partitioning the stomach. Part of this operation is based on the fact that we can hormonally make a big difference by excising part of the stomach. And here's the numbers sort of out to 2016. You can see that the number of gastric bypass is about a third. The number of sleeves is growing steadily. The number of bands and other endoscopic procedures are actually quite infrequent. Now, here again is the laparoscopic gastric bypass. And more than just how we do it, I think, is what does it achieve for us? This is an example of Whitgrove and Clark, the first person who did a laparoscopic gastric bypass, large series of patients, and a good number of them had GERD, multiple acid meds, hypercholesterol, diabetes on insulin, wearing CPAP machines for their sleep apnea, multiple medications for hypertension, medications for disabling arthritis. And preoperatively, you can kind of see what these folks were dealing with. And 6 months later, you can see the resolution of comorbid conditions. So one of the things I'm going to be looking for in the endoscopic presentation is a picture that shows me that you're getting these types of health advances. See, it's sort of like this. If you look at someone preoperative who's waiting for surgery, that's sort of that little circle on the inside, and you compare them to healthy people in that big circle, what you want to do is get that circle of health on all these different axes to be a little bigger. And at 1 month, we make a little bit of improvement, but we continue to follow in 3 months and we have restoration of health. This is pretty dramatic. It's not seen in anything else in medicine that can achieve. This is our typical patient, and this is our typical post-op. I think in this picture, at least, a picture is worth at least 1,000 words. The lap band is not commonly done, but let me explain to you that the outcomes for this procedure are still quite dramatic. By taking a band and placing it around the bottom of the stomach, we partition the stomach in a way that we get some stretch above, some fullness, some satiety, and we can help people lose weight. These are two of my nurses on a book, and these two nurses had resolution of their comorbid conditions, improvement in their quality of life. They're going to live longer. We know the data. But the key thing here is outcomes vary widely with this procedure, and that's why you don't see us doing a whole lot more. Anywhere between 30 to 70% of your excess body weight loss is achieved. So 30%, that's on every 100 pounds, you're losing 30. And in surgery, we don't think that's enough, or at least a lot of us don't. So again, I would like to look at the endoscopic procedures and get a feel for how many of those are losing 70% of their extra body weight, because those would be ones compatible with our least invasive procedure, the lap band. Well, let's look at diabetes. I wanted to pick out one thing. Well, with the lap band, 48% of people have resolution of their diabetes. With the gastric bypass, 84% have resolution of their diabetes. The mortality is small. But this is the picture that should get your attention, because this is achieved with surgery and for which there is no data endoscopy. And what this shows in the New England Journal of Medicine is that a weight loss procedure, surgery, is able to prolong life. There's a survival advantage of the intervention that's prolonged and sustained. Now, gastric sleeve is what I do most commonly these days. And again, we talked about the fact that when you try to mimic that endoscopically, you leave the stomach in, which is at least half the operation. But when we do this, our results are pretty good. We lose almost as much weight and we have almost as much resolution as with the gastric bypass. Now, there's other ways we can do things less invasively, and the data on that is still sort of pending, but it looks promising. I want to bring yourself also to the new standards. When we're talking about diabetes and what does the ADA say, they're now saying that in high volumes bariatric centers, when your BMI is greater than 30 and your sugar is not controlled, it really warrants a look at surgical intervention. So here's a study from the New England Journal of Medicine. It sort of outlines what you get with a diet. That's the blue line on top, not much. Banding, vertical banding, gastroplasty in the middle, gastric bypass, you lose the most. And if I had to guess with the endoscopy, and I'll be interested in the presentation tonight, I bet that line is somewhere up there with the pills. The key to the success of this is not the intervention, it's the program. And our program in bariatric surgery seeks to treat the whole person. It's a multidisciplinary team approach. It's not outsourced to a vendor. And we really do provide ongoing support and encouragement, looking at B12, iron, calcium, folate, lots of things. So when I saw the title of the proposed topic, I said, surgery then and endoscopy now. It seems like the battle, the gloves were on and determined before the debate. I kind of felt like the surgeon waiting for the endoscopist to get in there and put some extra clips and fasteners that I'll have to work around later. But I think a better title might be surgery then and surgery now. We've made a lot of advances in surgery, and I think surgery is really the mainstay for patients with severe obesity. You know, I think when we're talking about endoscopy and surgery, the real truth is when we're talking for bariatric surgery, we're talking apples and oranges. You're talking about surgery for the patients that are big with severe obesity, and maybe endoscopy for the patients who maybe aren't as big and maybe not as sick. And really for primary therapy for severe obesity, maybe we're talking about endoscopy not at all, until we get a lot better randomized controlled trials. So in summary, severe obesity is associated with serious health problems, complications, and early death. Severe obesity does not respond well to endoscopy and their interventions. They often require multiple procedures. They're rarely covered by insurance, and they lack long-term randomized controlled trials, the basis of all medical decision-making. Bariatric surgery, however, has a track record. We cover and document every single case that we do as a group. Operations are relatively safe, durable, and effective. Thank you.
Thank you, Dan. That was great. We'll go ahead and for the sake of time, I'll welcome Vivek to the stand and we'll let you drive your talk.
Thank you. Dr. Jones, if I could ask you to stop staring your screen, please, so I can share mine. Thank you so much. And so while I get the presentation up, I thought I really enjoyed that talk, and I thought I'd make a couple of comments. If you saw that table that Dr. Jones presented initially, you had sort of pros of surgery and the cons of endoscopy. What you didn't see, unfortunately, is that nobody wants surgery. So as effective as surgery is, if nobody wants it, well who cares? So I think the fact that less than 2% of patients who have their payers ready to cover surgery adopt surgery tells you that 98% of people sort of feel the same way I do about surgery. So that's fine. And we do cherry pick our patients for endoscopy. It was a note by Professor Jones that we do cherry pick the right patients, and that's something we're particularly proud of. And as we sort of are new to the field, we will continue to do that. I do credit the surgeons for getting on board with the MBSA equip. I think these registries are important. We're doing the same thing with endoscopy now. And in fact, we actually contribute to the MBSA equip sort of database as well. Any endoscopic bariatric procedure is part of that as well. So I think that's important. But from what I hear from surgeons, that they sometimes find that a nuisance. You've got to remember that with everything Dr. Jones said, that there's a whole field that's emerging now with managing weight regain after surgery. So I think the idea that surgery is a durable therapy needs to be revisited. And last but not least, the proof's in the pudding. That there are many surgeons now that I train to do endobariatric procedures. So if surgery was all that good, why are these sort of world-class surgeons bothering with the silly things we do? Clearly, there must be some merit to it. So I think hopefully that's a reasonable intro to where we're going here. And again, what Dr. Jones nicely pointed out was the hard endpoints that surgery does achieve. And I tell you, I credit the surgeons with doing high quality research. And that's something that we don't do as endoscopic bariatric therapists. And we need to learn from that. They've really changed the field. They've garnered reimbursement through their high quality prospective randomized control studies. And we need to do the same. Now, if you look at this, the change in BMI, this is the results of a randomized control study on relatively low BMI patients. I think these were 30 to 35s, published in New England Journal of Medicine. Yes, you see that the LSG, or lap sleeve gastrectomy, is equivalent to the gastric bypass in terms of outcomes. But what people forget to comment on is if you look at weight regain, patients in the setting of a high quality, multi-million-dollar randomized control study, patients are still gaining weight as early as 18 months. And if you looked at the data Dr. Jones presented on the Swedish obesity study, you also saw that blip in weight regain. So clearly, if you're being hacked at by surgeons and still gaining weight at 18 months, we expect that some nimble endoscopic procedures will also result in a similar problem. Now, in terms of how much weight do we need to lose, I agree that we need to set the bar high. What we know is that with total body fat loss, there seems to be a preferential loss of intra-abdominal and intrahepatic fat. And so that's important to know. And so in my mind, if you're hitting 15% total body weight loss, data shows, through sort of MRI sort of data, that you'll actually achieve 30% reduction in visceral adiposity, the toxic fat, and a 65% reduction in hepatic lipid content. So you get that with 15% total body weight loss. So where could endoscopic bariatric interventions fit in? One, clearly we've learned from surgery that even if you have something that is effective, if nobody wants it, it doesn't matter. So it needs to be a palatable concept. Patients need to think of what you're offering and say, well, that makes sense. That sounds all right. Let's do it. It needs to be safe and it needs to be well tolerated. And I think we've had some issues with balloons, of course, because although conceptually it makes sense, there have been some safety concerns, and certainly tolerability is not always the case. So we've learned from that and we're moving on. Regarding BMIs, I agree that the surgeons are getting into the BMI 30 to 35 now. And so we need to look elsewhere. And in my mind, we should be aggressive and go early. If you have a safe procedure, I see no harm in offering it to a patient who's got a BMI of 25. Something that we can do that surgeons can't is a repeatable procedure. There's not much you can do after you've had a gastric bypass apart from lengthen the limb or alter the size of the gastrojejunal anastomosis. So with endoscopic interventions, they're often repeatable and/or they're reversible. And I think that is an advantage. If we do need to reverse it because of a new future technology or future surgery, then we're able to do so. My vision for the future is that there is some tech that you buy from a pharmacy or buy online, and you swallow it, and it'll do things to your stomach that'll work, negating the need for surgery. So you've probably heard of balloons. You may have heard of this device, this transpyloric shuttle. These are intragastric devices. And you can see some of the new iterations of these balloons do hit the near 15% total body weight loss at 12 months. That I think is a reasonable target. What's also interesting is that even though these intragastric devices, due to the fact that they need to be removed and not enduring, they still work with, and they're only approved for BMIs 30 to 40. They still have efficacy in the BMIs 50s and 60s. So I think there is some benefit in the super obese. Now whether that benefit is clinically relevant, that's a different story, but they do provide some benefit. So the most talked about endobariatric procedure right now is the endoscopic sleeve gastroplasty. And this is basically a procedure where you try and emulate the luminal anatomy of the stomach without resection by running sutures along the greater curvature aspect, taking the stomach from this floppy expandable bag into a non-compliant stiff thin tube. So you have a suturing system mounted on an endoscope. You start 3 centimeters from the pylorus. You go to the gastroesophageal junction, and you end up with a lumen that to me looks very similar to a surgical sleeve. And so people often ask me, look, we tried laparoscopic gastric plication in the past. It failed. Why are you trying to do the same thing with an endoscope? And so I looked into this, and what I actually found is that at 12 months with gastric plication, so this is a surgical gastric plication, excess weight loss was similar to what we saw with the lap band, somewhere between 46 to 67%. So gastric plication works. It's not as effective as a laparoscopic sleeve gastrectomy, but to say it doesn't work is incorrect. So I think we do have a justification to do a endoscopic plication method. And so this is data on ESG. Now, granted, this is a culmination of retrospective studies, but we see that your total body weight loss is 16% at 9 months, 17% at 12 months, and so it sort of stays in that region. And yes, as you follow patients out, you probably are going to regain some of that lost weight. And there's 5-year data by one group that shows a 14% total body weight loss at 5 years. Now, again, recording adverse events in retrospective studies is problematic. They're likely to be underreported, but the rate of serious adverse events is 2%. What happens to the stomach over time? Sutures, like any foreign material, are going to be spat out by the stomach. If you suture the skin, it's not going to stay in, the sutures aren't going to stay in position for 5 years. So you see this in the stomach of an ESG as well. This is a patient 9 months after their procedure. You see the sutures have dehisced. That's not surprising. There's tissue regeneration, asset, a lot of movement. If you follow the greater curvature aspect of the stomach here, you see that there is some fibrosis of the greater curvature aspect all the way up until the fundus that you'll see here. So is the stomach as small as what I showed you on completion of the procedure? No, but it's certainly not back to normal. And we recognize that we need to do better. So we've actually done some work looking at combining a mucosal ablative strategy with ESG, and we're actually able to actually, within an hour procedure, actually create a tubular stomach. Now, how does ESG compare to laparoscopic sleeve gastrectomy? Well, it doesn't do as well from a total body weight loss perspective. And I think there's reasons why, and we can speak to that. But what we do see is that there is less new onset reflux. And new onset GERD is really one of the Achilles heel of the laparoscopic sleeve gastrectomy. Now, again, where is the level 1 evidence? It's coming. It's being presented by Eric Wilson, who's a surgeon, and Bahum Abadea from the Mayo Clinic. And they have done a very nice multi-center study that we contributed to. And the results will show you that in this trial comparing ESG to diet and lifestyle, there was a clinically significant benefit. And I think what we need to remember here is that, unlike the coronary artery bypass, we approach endoscopic bariatric therapies in the same way as a cardiologist might do coronary angioplasty and stenting. Yes, you do a procedure, but then you follow with pharmacotherapy, which may well be lifelong. So I get a lot of criticism for saying, well, you're combining 2 different approaches. Why would you do your medication approach if you'd only offer medication if your initial procedure failed? Well, clearly that's not the case in medicine. And as we know, cardiologists have basically destroyed the livelihoods of cardiothoracic surgeons. And so I think the GI endoscopists will probably do the same. And so what we can see here is some data that we published comparing GLP-1 receptor agonist, liraglutide, with an intragastric balloon, with a balloon alone. And there is some statistically significant benefit in weight. We've done the same thing with ESG plus liraglutide versus ESG alone. And we also see that when you introduce liraglutide at 5 months, there is, we get at 12 months, actually 25% total body weight loss. So you can see here, this is getting pretty close to surgical level weight loss. Combining an ESG with a pharmacotherapy is giving you almost surgical level weight loss. And we've done the same thing with semaglutide as well, where we're seeing 25% total body weight loss at a year. Now, the future, I think, is using intragastric devices potentially without an endoscope. And this is an example of Gelesis, a capsule that you swallow, little beads, you drink some water, these hydrogel beads open up in your stomach, occupy space. And interestingly, the clinical benefit was marginal over placebo, but I like the way the field is moving. There's something called Glycend, which is a capsule that you take before your meals, and it will coat the small intestine, hopefully recapitulating some of the small intestinal incretin type effects that we see with the gastric bypass. So really the field is moving away even from an endoscope, which is particularly exciting. In my mind, what are the ultimate goals of an endobariatric therapy? One, it should be have a similar efficacy to bariatric surgery. We're going to get there. We're not going to be sort of inferior to surgical outcomes. We're going to have similar efficacy. We're going to be safer than what bariatric surgery offers, and we're going to be more cost effective. And let's think about the perspectives of the patient here, as well as the providers and payers. So patients want an outpatient, incisionless, well-tolerated single intervention procedure. And I think we're moving that way with endobariatric procedures. The providers want a technically simple, it should be performed under conscious sedation, should be safe and effective procedure, something that all GI endoscopists can perform. And payers obviously want something cost-effective with long-term improvement of metabolic outcomes. And I think we recognize that in the endobariatric space. And as Professor Jones nicely pointed out, we haven't done enough to look at harder endpoints, metabolic endpoints, and we focused a lot on total body weight loss. But we are learning, and I think some newer data is actually more focused on metabolic therapies as opposed to simply weight loss. So at that point, I'll stop there, and thank you very much.
Well, thanks, Vivek. That was an excellent overview in a relatively short period of time. And both of you did a great job. I think, so at this point, we're in the so-called rebuttal section. So where, both of you get to pick each other's weak points and attack. So I think since you just finished, Dr. Jones, I'd ask you to see if there is any couple of pointers that you want to throw back at Vivek, and then he will get an equal opportunity to strike back.
Well, I think he's absolutely right that nobody wants an operation, but actually the only thing people don't want more than an operation is a bowel prep. And no one wants an operation they can't get insurance coverage for. And no one really wants a procedure that they have to come back over and over again and deal with parking and all of that. So while it might be good for the provider to do something repetitively, I'm not sure that's really what the patients are looking for in terms of repetitiveness. I do think they want data. I do think they want randomized controlled trials. I think they want them well done. I think they want lots of them to really get a feel for what they're doing, rather than say one's just less invasive than the other. So I'd ask you this: you have a 55-year-old gentleman. He has a BMI of 60. He has type 2 diabetes. Comes to your office. What are you going to propose to him?
Yeah, I mean, I think there's level 1 evidence for bariatric surgery in that patient cohort. You know, patients who've got type 2 diabetes, particularly if they're on insulin, patients with end-stage disease, you know, such as NASH or liver fibrosis secondary to NASH. You know, I agree with you. I will spend 90% of my consult begging them to consider surgery and not have an endoscopic therapy.
About a third of my patients, well, all my 3 patients I had today had a hiatal hernia that I was able to fix while I was operating. Patient comes into you with a BMI of 40 and has a pretty good size hiatal hernia with bad reflux as one of those comorbid conditions. What are you going to recommend?
Yeah, I think, you know, we've actually, if the hiatal hernia is greater than 2 centimeters and is symptomatic and needs to be treated, well, sure. Again, surgery may be a reasonable option. You know, not all hernias need to be treated, particularly if they do have some symptoms of acid or non-acid reflux. Potentially losing weight could be a benefit. I believe surgeons prefer to operate on patients with less intra-abdominal fat, so maybe doing a repair after an endobariatric procedure could bring some value. But you know, our endoscopic procedures, particularly the plication procedures, don't seem to precipitate reflux. You know, yes, the gastric balloons do.
That's because they're not being held together. They all come undone.
Right, they do, and just like the surgical.
And then there's no reflux.
Or maybe even early on, you know, within the first few months.
They were never small to begin with.
Yeah, we are a deceptive bunch. You know, as I showed you my videos, I made sure I didn't hit the insufflation too aggressively here to make the stomach look small. But yeah, you know, I think I think reflux is a very serious problem, and if you do have someone who has reflux and a hiatal hernia, I suspect you're doing a gastric bypass if the patient will let you.
No, a third of patients will do actually very well with a sleeve and a repair, but those are things we can debate later. I do think you're correct that there's the role probably for a combined therapy with medicine is the way to go. You know, I would have thought more of the endoscopic procedures if you compared endoscopy to surgery rather than the medications and endoscopy to surgery. But I think surgery with medicines has a lot of value. And so when you're talking about people with a little weight gain or something, we have a lot of folks who we can have behavioral interventions and some medications, medical therapy, and it does the trick quite well. So I think there's a lot our medicine colleagues can offer us once they have a bariatric procedure.
You know, I agree. I think your point about ghrelin and other gut hormones was well received as you were talking about sleeve gastrectomy. And one of the things that we haven't been particularly successful in is altering gut hormones without endobariatric procedures. That's why, in my mind, that the synergy between an anatomical procedure that alters anatomy and combining it with a procedure that sort of alters hormonal pathways might have more benefit than, or not more benefit, but might be a more logical strategy than a surgery which alters anatomy and hormones, and then adding a pharmacotherapy which also addresses the hormonal influence on obesity.
Yeah, I think
in full disclosure, Ram Shatani and I 15 years ago had the NDO, and we were trying to partition the stomach to try to create the channel. And the more we learned about ghrelin and the hormonal effects, the more that seemed like a Band-Aid rather than a fix. Plus the NDO didn't work, went out of business.
Yeah, I think the point that came up just now, if I may interrupt, is endoscopy, bariatric endoscopy has to be looked in the context of the metabolic clinic. And I think that's the point Vivek made earlier, and you, of course, accepted and conceded that. I think, especially going forward, it's not a silo of just endoscopic intervention. It's the whole package. Vivek, do you have any particular pointers to pick on Dr. Jones here before we go to our formal Q&A?
Yeah, look, you know, I'll be honest. At very early on in my career, I desperately wanted to be a surgeon, and then I was
It's not too late. You have some skills.
Then I was introduced to GI endoscopy, and I said, "Oh, this is going to be the end of surgery." So I'm very happy with how things ended up. But you know, why is it that surgeons don't make more effort with regarding to reassuring the obese population that surgery is safe and effective? You know, why? You know, they keep talking about this is effective, this is effective, this is effective. I get it, but clearly there's a perception that surgery is dangerous, if not deadly. You know, how did that happen, and what can be done to fix it? The reason I ask is that, you know, I want to learn from the surgeons how to address this when it comes to endobariatric procedures.
Yeah, you know, I think early on, the guys before me, they were doing big open procedures. So I think that was part of it. And they were taking care of the sickest of patients with the worst disease. And where it was kind of a, you know, really a Hail Mary trying to get people through. It was new. They didn't know about vitamins, B12, iron, calcium, folate, thiamine. They didn't know as much as they do today about marginal ulcers and other kinds of complications. There wasn't a database, so everyone was just kind of doing their thing. And all the data wasn't being tracked, and people didn't have meetings where they could talk about how to do things better. So it was really in the early days where they didn't have the science, they had the cowboys. And now that's very different. Now we're probably the most science-based specialty of all of surgery. We're probably the most interested in patient safety and the accreditation of our programs, fellows, and surgeons. We cover our data, all patients in our database, and we have pretty high standards. So you're right. I think times have changed over 30, 40 years, and there's a little bit of a lag, but I think there's something to be learned from that process as the cowboys of endoscopy take off and try new things.
That's very true. And, you know, I have another question that's often asked to me. You know, the big push for endobariatric procedures is that it is an outpatient procedure. I understand that surgery is now being done not infrequently as an outpatient procedure with reasonable outcomes. You know, is that really the future of surgery? And if so, then one of the major benefits of endobariatric therapies goes out the window.
Yeah, so absolutely, lap band for lots of people was an outpatient surgery, and that was achieving 30 to 70% excess body weight loss. So if you compare the lap band to other ambulatory procedures, it would do quite well. When you look at gastric bypass, very few people have done that as true outpatient. The sleeve procedure is growing in popularity to doing that, but I think it's because, and really in communities where you can really have close follow-up, I think that COVID might help advance that as we have telehealth and telecommunication and other ways of communicating back and forth. We may be able to do things safely as an outpatient. But again, I think it'll be an evolution. Remember lap choles when they were first done was an overnight stay, and pretty much everyone goes home with them today.
It's true. I think you alluded to remote patient monitoring, which is
right.
It's got a new life now, and there's a lot of startups and well-established companies that are investing a lot of equity in that space. To more,
it makes sense, right? If we can talk to you and take your vital signs, and especially if we had a way to get an IV done as an outpatient,
yeah, it makes a whole lot of sense.
It would be a different ballgame.
And the reason that remote patient monitoring, especially in these particular areas, is is not in general hasn't taken has gained too much traction is because of the logistics and the legalities and the operational hurdles that it has. Not the concept is very valid, and I think it's at least in some part a glimpse into the future. So. I think you guys really tried very hard to shed some blood. Your talks were very incisive and to the point. I appreciate, and Sri and I both appreciate you keeping it to the time. We are at the 40-minute mark. And guess what? We have some questions. So one of the questions is aimed at both of you, can take a crack at it. One maybe Vivek first, is do you incorporate foregut dysmotility, gastric emptying studies and such? Should that be a marker as you decide, what intervention, any intervention, is that a problem, not a problem? Any insight into that question?
Yeah, it's a great question. One of our major barriers to doing high quality research in general and sort of true physiologic investigations prior to an endobariatric procedure is that the final procedure is not reimbursed. And because it's pay out of pocket, it's hard for us to justify going down the path of extensive testing unless someone is clearly symptomatic or we believe there's an underlying gastrointestinal motility disorder. So no, we very rarely do. Now, there is some data that I don't fully buy. I'm interested in Dr. Jones's opinion here that in patients who are rapid gastric emptiers at baseline, doing a procedure that decreases gastric emptying may confer more benefit than those patients who aren't at baseline rapid gastric emptyers. You know, one of the things I find curious is that, you know, surgeons sort of look to the surgical sleeve and the gastric bypass as a method of sort of increasing nutrient deposition in the small bowel at a rapid cadence as it's one of its mechanism of actions, whereas the endobariatric guys seem to suggest that slowing down gastric emptying confers benefit. And so I think there's a problem there that we need to resolve, but interested in Dr. Jones's thoughts.
Yeah, I don't know if the milk is half empty or half full, but you know, typically if we have a problem with gastric emptying, that might persuade us to do a gastric bypass where, you know, emptying the stomach's not part of the procedure.
Right. I mean, I think it's something to think about. And, you know, patients, it's hard. You know, I think at this BMI level and with the comorbidities some of these folks carry, it's conceivable that they have some degree of dysmotility or some confounding presentations and symptomatology. So but I think, Vivek, to your point, I think a gastric emptying study as part of the overall clinical care might still be reimbursed, but it may fall outside the packet that you agreed upon. Which brings me to another question is regarding reimbursement. We want to go through that really quickly. It's a big topic. You know, so obviously cash paying for the most part, awaiting more level 1 and some level 2 evidence to get it through CPT and other areas there for the remaining interventions. So any thoughts on that, Vivek? How do you manage that? Any pointers to our audience to get reimbursement going? What tricks, tips, pearls, caveats do you have for our team watching tonight?
Yeah, I think it's hard. I think the way the surgeons did it is that they got the data that the payers were looking for, and so I think we need to learn that. You know, there's actually multiple randomized control studies showing that surgery is effective in BMI 30 to 35, right? And still, there's not universal. This is even without patients who are poorly controlled diabetics. And so even with that, there's not universal reimbursement in that surgical population. So
there is universal consensus across 35 societies, medicine, surgery, ADA, that surgery is the correct treatment option for 30 to 35 with poorly controlled sugars. In terms of reimbursement, I think there's some lessons you maybe think through. It used to be when we weren't covered by insurance, we got paid 3 times as much. Now that all my patients get approved, they pay me a third as much 20 years later.
Brian, it's very interesting, isn't it? And one of the you know, the thoughts here is that if endobariatric procedures do get reimbursement, what will that mean? Will it mean they'll have to go through a 6-month rigmarole that patients have to do before they get their bariatric surgery? And is that going to be a deterrent? Well, that makes sense to me. Secondly, will there be, if it is reimbursed, is there motivation to lose weight less because they're not forking? You know, we see this in funded studies. Weight loss seems to be less than in studies that roll out in sort of real world populations where they're paying for their procedure. And so if this does become reimbursed, will outcomes be inferior to the scenario where they do pay out of pocket? So is that a path that we want to go down? And then of course, as Dr. Jones mentioned, physician reimbursement is going to be like an EGD. I mean, then you've got the challenge of this patient population. You know, who's going to want to do it?
Over time, reimbursement dwindles. The same story with ERCP, EUS, and the same with other things. Question from the audience about sleeve gastrectomy complications. So Dr. Jones, you painted a very rosy picture for surgery and the total body weight loss, but we all
It was only rosy because I was comparing it to an endoscopy.
Understand. That's a relative value unit. But rosy nonetheless, you certainly have more robust data and more years under the belt. with that intervention. So the question comes up is, we all have seen sleeve gastrectomy complications, and in the trial sleeve gastrectomy surgical versus endoscopic, the one thing that was really in favor of endoscopic was the morbidity. So how do you justify, and how do you, kind of get around the fact that when these complications occur, even in the best of hands, like those of Vivek's and many others, it's very hard. Those were some of the hardest cases to bring to justice. So something to keep in mind, the sleeve gastrectomy complications.
Yeah, so several of my sleeve gastrectomy complications cases are cases where they had the endo sleeve first and it failed a few times, and then we gave them a definitive sleeve. So those are some of the people I see, and those are just a little bit harder because now I have pieces of this and that, that I have to cut through and cut around. So are there complications of surgery? Absolutely, right? That's why nobody wants an operation if you don't need one, but then it's a risk benefit, right? I told you that the surgeries I do are going to resolve your diabetes. It's going to get you off sleep apnea machines. It's going to get rid of your hypertension, your back pain, your knee pain. For many people, it's going to give them a new life. And if you can achieve that without a cut in the belly, great. But right now, it's still aspirational. It's an aspirational goal for endoscopy to be efficacious, safe, and durable. And saying it's good because it's reversible and repetitive, I don't think is the way to go. But that said, I do envision a way you could partition the stomach and give a pill and achieve very similar, if not identical results. And so please don't give up looking at it. In terms of complications, usual complications of a sleeve are based on, well, any operation where you get DVTs, PEs, intra-abdominal clots. You can talk about mechanical issues. Those can be that it's too narrow or too big. And so we use a bougie to help guide that. Usually I use a 36 French bougie. But you can still get a twist, the kink. A leak is I haven't seen one, and I've done almost 1,000 cases now, so they're rare, but I talk to everyone about them. But I've seen one from Mexico, so it's not like they don't occur. But the twists, the kinks, the nausea, vomiting, those things can occur after endo sleeves. Those can occur after laparoscopic sleeves. Those can occur without any sleeves. Mm-hmm. So they are things that we go through, and part of the process of getting ready for surgery is to really go in detail, not only the lifestyle changes that are going to be expected, diet, exercise, sleep, but also a good understanding of the complications that may occur. And this is where, surgeons need endoscopists, right? Because if there's a kink or twist or something, you guys have an achalasia balloon that can pop that sucker open and fix it. You guys are worth your weight in gold when it comes to fixing some of the problems that we do see, and really making it a lot better for patients.
Well, I think that's the point of the whole discourse here, is that this is a team effort. And I think, in a particular given situation, one option might be more attractive than the other. But
I think if you had one conclusion you want to make, I think that the best thing going forward as you're blazing a new pathway, and that's what we're talking about, right? We're trying to take the principles of surgeries and the techniques of endoscopy to try to make a less invasive operation, combine it with medications to achieve the same results. And I think this is where you really need your endocrinologist who's familiar with the medications and the science of the pills, the endoscopist who, if they're not a surgeon, being a GI endoscopist, and a surgeon who can really be there and collectively, as old Ram Shaitani and I were trying to do 15 years ago, make it work. But once you make it work, you got to have the science, you got to have the data, you got to follow it. It has to be clean, and we got to be able to trust it. That's
great. Sorry, Vivek, go ahead.
And I think we're learning that. We know that surgery works. We don't know how it works, and that's a whole field, right? And so, and I think it's critical once we understand the critical elements of what makes surgery so effective, then we can either just apply that with an endoscope or potentially with a pill. So very promising. Regarding the cost benefits, again, I spend a lot of my time convincing patients to have surgery, in fairness, because there's evidence for it. And so I appreciate there are risks with surgery. However, there's good data to show there's a mortality benefit. There is a cost-effective it's cost effective, and so I think I think that shouldn't be a significant barrier. Now, it is a problem when someone does have a complication of a sleeve, for example, and the most feared complication is a leak. You know, so they are reluctant to get a reoperation, and I think it becomes a challenging situation in that case, because they've had one surgery which has resulted in a poor outcome, and to convince them to have a sort of maybe a definitive surgical fix to that can be really hard. So we often spend months with these patients, as you know, trying to rectify the situation endoscopically. Often successful, but difficult.
Very quickly, a contentious question from the audience. Good participation tonight for Dr. Jones. Really quickly before we go to the rapid fire, those surgeons, and it came up in your talks as well, is those surgeons are doing endoscopy now. Obviously, they're somewhat motivated to get that skill set and believe in it. But at the same time, they do belong to societies that are advocating for surgery and reimbursement. So any insight into how those leaders and those experts are trying to juggle the two worlds, and how they navigate that dichotomy?
I mean, the most common procedure that a general surgeon does who's not associated with an academic center is a colonoscopy.
Correct. That's a good
period.
point.
It's not an appendectomy. It's not a gallbladder. It's a colonoscopy. They may not be doing much more than that through the scope, but that's the most common thing they do. There's a handful, as you said. Eric Wilson is one of your champions earlier, who's a surgeon who's able to bridge the world of endoscopy and surgery in a way that we expect going to advance the field. And so I think what we need to do is have the gastroenterologists and the surgeons really lock arms here and make a few targets and see what we can do together, as people tried to do with nose cars and other things in the past, and bring joint societies together, working for reimbursement. Because right now, your biggest obstacle to doing cases isn't the surgeon in the office down the hall, is some bureaucrat in an office. He doesn't understand what you're even doing. And so I think the real thing is to work together, both on the science, the innovation, and the policy, healthcare policy.
Very good. That's well put. And I think the analogy with colonoscopy is very well received. So now we're in the rapid fire time, so we can get as many questions really quickly, very, very quick answers to very quick questions. So I'll start with Vivek. For weight regain, TOR or surgery?
Yeah, so the transoral gastric outlet reduction is basically a procedure that reduces the size of gastrodigital anastomosis. Marginal benefit, somewhere between 5 to 10 kilos at 6 and 12 months. And most of the time it suggests that we need to repeat that again for perpetuity, potentially on an annual basis. So
I'm across the street from where it's done the most commonly, and I don't think there's any success.
Understand. All right. So sounds like there's equal weightage there, and depends on where you are. In terms of biliary complications from bariatric interventions, Dr. Jones, do you see in your mind any difference, surgical versus endoscopic? Because we see a lot of these cases coming with pancreatitis, with biliary microlithiasis, and change in milieu of their bile duct composition, bile composition. Any thoughts on that?
I honestly don't see much of that. I see a dilated duct now and again, but nothing that anyone gets too excited about.
Okay, Vivek.
Yeah, I mean, I think the reason why the increased biliary pathology in this population for surgery is more effective from a weight loss perspective. So that's probably why you're seeing it more often.
It's the degree of alteration in the metabolism. Comments on semaglutide, the new kid on the block here. Vivek first.
Yeah, obviously, high quality data, New England Journal papers on this. I think it's brought excitement to the weight loss field, which I think is important. It gives people hope. But as with anything, let's see how it rolls out. Let's see who covers it, and let's see if there's sort of any side effects that are brought up.
Right. Well, we have a poster, this ACG on a DILI related to it, which will come out. Daniel, do you have any role for semaglutide in your practice?
Again, we have medical weight loss programs that will get involved when people might come back and have some weight regain after years of surgery.
All right.
The best problem with this is it's not always covered by insurance and can be costly.
Right. So I guess a question came up earlier: is endobariatrics as a bridge to surgery? Yes or no, Vivek?
No.
Not as a bridge. Bring a super high BMI down to to a level where the surgeon might be more comfortable for a more durable.
Yeah, there's actually some nice data on looking at putting super obese patients, putting an intragastric balloon in, and then having a bypass versus going straight to bypass alone. There's marginal benefit in weight loss in this randomized control study, but it was very marginal. So I think added expense, added risk of adverse events for marginal benefit. And as Dr. Jones mentioned, he's continuing to complain about these ESG, these tiny little tags that we leave behind in the stomach as ESG is causing this dramatic
getting in my staple line, trying to generate more business for you. But I do think the idea of a bridge, there's someone who's really not quite healthy enough for a gastric bypass. Those are patients that's how we got the sleeve to begin with. Those were for patients that we couldn't do a gastric bypass on safely. And someone said, hey, look, maybe we could just do a sleeve and come back to them when they're 100 pounds less. But truthfully, they lose so much weight. We almost never do that second operation. And so, the concept of a bridge was a good one. That's how we got the sleeve to begin with. And it is true that I think most of your endo sleeves are a bridge, whether we think of them that way or not, because they fail enough time that eventually they get a definitive surgery. So we're not against you doing them. It's just a long way to get to us.
And I would just add a comment. There are many patients that have had an ESG with diabetes. They managed to lose 50 pounds. Unfortunately, they're still requiring insulin. And so they go from a patient who's disinterested in surgery, has had an ESG, but is now open to surgery. And
Correct.
So I think there's some lessons there too.
Yeah, look, they would have never come to me directly because even though they had insurance, they weren't mentally ready to make that step, as you pointed out, right? And to help them get there, we brought them to the endosuite enough times that they thought it might be easier to do surgery.
It's fun. So last question before we close out here. Duodenal mucosal resurfacing, Vivek, is it going to throw all of you guys out of business or what's the deal there? Real quick.
Yeah, I think it's exciting. Again, in my opinion, we need to move away from implants. The GI tract simply doesn't tolerate implants. So I like the idea of refashioning tissue without leaving something behind. Now, doing a single ablation effectively, I think it's very unlikely to provide enduring benefit.
I think it's really the first foray into metabolic endoscopy. But
the only thing more interesting is studying the microbiome.
Understand. Well, with that, we've had, there's no end to questions, but I have to take the poll now and let's take a look. And if we can launch this poll, who won tonight's debate? And here we go. So let's take a look with the remaining participants, attendees rather. We'll give it a minute. And again, this is a friendly poll. So we'll try to see. We had a bunch of surgeons.
Vivek, I'm trying to vote for you and they won't let me.
Yes.
We are not allowed to vote as the panelists, so we should be good there. We're so far an even split here, which is amazing. You guys really did very well, and I think the debate was equal parts academic and practical. Both Sri and I are grateful for you guys taking on this challenge at a relatively short notice and bringing to conclusion with this particular episode the 4-part series aimed at foregut disease.
And let me just, if you let me, thank
please.
Again our GI colleagues, because surgeons can't do what we do without you guys, and we appreciate you a lot.
And I'm sure, Vivek, your sentiment is reciprocal there. Yeah.
We're happy to help.
Yeah. Like to go on. So it looks like, this is the closest poll, and with the variation in the GI versus surgery attendance, I dare say that this would be an even split, and congratulations to you both. Thank you again. And just a reminder to the attendees that this concludes the 4-part series, but this particular episode will be available, I'm thinking, by Friday on the app. And all you got to do is download the app and then go to the virtual education area and then hit past episodes. A little note that Sri and I will talk about where we can go from here on the thematic webinar platform. This was foregut, and if there is interest, we'll certainly think of other areas as well. Any final comments from you, Vivek, Daniel?
No.
Appreciate the opportunity to be here, and it seemed like a great program. Thank you.
Thank you very much, Vivek.
Thank you. Thanks, Dr. Jones. Thanks, Dr. Cole. This has been a lot of fun.
That's great. And on behalf of Sri and myself and Jim Armstrong from Endoscopy Now, and John Lippam and the AFS team, Kate, really been a great journey with over a month. And we thank the attendees who've had the fortitude to staying with us late evenings. Thank you again, everybody, and we hope to see you back here on a different theme another time. Thank you. Good night.
Good night.